Yeah. So thank you, Central India CSI, for giving me this opportunity to present retrograde tips and tricks, in front of you. I'm Dr. Sharath Reddy from Hyderabad. These are my disclosures, anyway, not related to current presentation. And when do we go retrograde? So this is very important. When the cap is ambiguous and when the distal vessel is not clearly visible in angiography, and when you have a good interventional collateral. So these are the three places where we might end up in going retrograde, and sometimes even primary retrograde. The preamble for retrograde intervention is when patient has significant LV dysfunction. So retrograde can create a problem. So you can see this is a case of long RCS CTO where we were doing live in box, and we can see here we went through the collateral and we were externalizing the retrograde wire. And what happened while we were externalizing, you can see his heart rate gradually drops, and you can see here heart is laterally rate is dropped, and contractility is gone. Now people jumped on for CPR. So it has hemodynamic cost to pay, so that should be kept in mind, and we could revive this patient subsequently with MCS. Yeah, but MCS can be considered in significant LV dysfunction. Retrograde in a critical donor vessel disease. This is another thing which you have to address before going to treat your retrograde CTO. See here, it's an RCS CTO as well as LAD significant lesion, and LAD was a donor vessel. You can see these are the donor septals, and when there is such critical lesion, always address this. Otherwise, patient can go bad, during your retrograde intervention. So treat this. It doesn't matter even if struts are across the septal. You can go through those struts and you can finish procedure. But it improves the safety when you address donor vessel disease before touching your CTO. Coming to ambiguous cap scenarios, as I already mentioned, ambiguous cap is one area where we might go primary retrograde, but again there is a cost to pay in sometimes if the ambiguous cap is sitting right in ostial LAD. This is an ostial LAD CTO. So if you go retrograde without antegrade preparation, what can happen in this patient? See, if your retrograde wire comes subintimally and enters LMCA, so and you end up in dilating that track, so this flap can close LCX and patient can collapse on table. So this is what can happen in ostial LAD ambiguous cap CTO. So that's why the right ideal wiring strategy for these patients is first go antegrade, prepare antegrade with IVUS guided cap puncture. That is very important. If you don't have IVUS, And again, if your antegrade wire enters subintimally, so you can create same complication what we can create, by going retrograde and coming into LMCA. So it's important to have an IVUS guided antegrade cap puncture followed by go retrograde, and you can finish your procedure. So you can see here we did IVUS guided antegrade cap puncture, and then we went retrograde, and we externalized retrograde wire, and then we stunted from LM2 LAD. Despite all the queer, you can still see L6 ostomy is compromised because of intramural hematoma which was created in the course of reverse cart. So that's a problem which can happen. So we had to stunt even LCX in this case. So ostial LAD is completely a different animal, and taming ostial LAD CTO is very, very, very important. So you can go through this article of mine which is published in IJCC, which discusses all the techniques related to taming ostial LAD CTO. And coming to interventional collateral selection, so you have venous grafts, epicardial collaterals, and septal collaterals. Venous grafts are the best conduits. You can go straight away and then do procedure. You can see here, this is an ambiguous cap, and you have a good venous graft through which you can go and put an IVUS antegradely, and you can do a puncture. So venous graft is a good conduit, and less number of complications. You can also see here a venous graft stunted twice before stunt in stunt, and they are notorious for reblockages. So in our institution, we almost any venous graft more than 5 to 6 years, we generally tend to open native coronary CTOs, not the venous graft. So in this case, you can simply go across the venous graft, and you can open the lesion. So it's quite uncomplicated. But sometimes even venous graft is closed. You can see here it's a closed venous graft. So in this patient, and if it is closed less than 1 year, still it is amenable for retrograde conduit. So and how to go or how to track that venous graft is, you can take a pilot wire. This is a pilot wire, or any hydrophilic wire with a polymer jacket coating, and you can just do a knuckle. So go with the knuckle across the venous graft. You can see here I'm going across the venous graft because we don't know even the course of the venous graft when it's totally occluded. So, and you can see this knuckle clearly reached distal true lumen here. So in epicardial collateral, you can see here a lot of loops. That's tortuosity is the biggest problem in epicardial collateral. But if the size is good, so that is enough. Tortuosity doesn't matter because the technology of wires is so evolved nowadays. The CO03 wire is a quite good wire for epicardial collaterals. You can see so many loops, and you can see how the CO03 wire goes across within seconds. So that's the beauty of these low tip load, highly flexible wire. You can see here within couple of minutes we reached LAD through this epicardial collateral. So loops is not an issue, and size is the most important thing. If size is good, you can cross all these tortuosities. And in septal collaterals, you can see takeoff angle and joining angle with recipient vessel, and also the course of the septal and branching pattern of the septal. These are the things which decides your success of crossing septal collateral. You can see here the origin is quite abnormal. It's coming like cranial in origin, so entering such septals is quite difficult. And sometimes we can use double lumen catheter. You can see double lumen catheter here, so it's abnormally originating septal. I used double lumen catheter just to enter the septal and get into septal, and subsequently we can switch to your microcatheter. And angle of PDI origin, that is very crucial while selecting septal collateral. See, if you choose this septal collateral and later you realize this PDA is almost coaxial with PLVB, not with the distal RCA. So it is very difficult to turn your retrograde wire into CTO here. And sometimes we can use double lumen catheter to do that. Retrograde double lumen catheter, that is Sasuke, can be used in these case scenarios. But better choose a vessel, which has a good distance from the distal cap. So that's important. You can see here the wire is just going into PLVB. And sometimes septals entry may not be into PDA. You can see in this case, the first septal I tried, but this septal is connected to RB branch, not to the PDA. So these branches are, very vulnerable for perforations because of acute angulation, which you can see here. RB branch joins your main RV, right coronary artery in a perpendicular manner. So chances of perforations while pushing microcatheters is very high. So try to avoid, these septal collaterals which open into RV branch. And coming to lima, when there is lima, always go to a septal which is quite away from lima anastomosis, so that you won't damage lima. And coming to the branching of septal, see, if you have multiple branches, it is difficult to navigate the wire. And instead, if septal collateral is single without much branch points, it's quite easy to navigate, this septal collateral than this branched septal collateral. You can see the same thing here. So it's non-branching but loopy collateral, but we could able to cross without much issue. And sometimes your septal collaterals entry into your recipient vessel. You can see here how it is entering. You see here how it is entering. So this is quite conducive for your wire and microcatheter movement towards proximal vessel, but this is not conducive. Usually your wire and microcatheter goes into the distal recipient vessel, and turning back into the proximal recipient vessel is very difficult. So these loops has to be paid attention before choosing septal collateral. And when there is epicardial collateral along with septal collateral, so it's very difficult to unearth your septal collateral. So unless you occlude epicardial collateral, you may not be able to see your septal collateral. So that's what you have to do. So we gave almost a pressure injection into septal collateral. That's when we were able to see it. Coming to viewing collaterals for wiring, so you have RAO, cranial or caudal views. Cranial for basal septals, and caudal for distal septals, that is apical septals, is a good thing to do. And that's how we can visualize. And when there is only single collateral, so it's very difficult. Patient might go into acute ischemia once your catheter is into that septal collateral. So you can see here there is no flow into PDA once catheter is kept into that collateral. So this is difficult to handle, and you always choose other techniques to do in these patients. So best wires are, my favorite wire is 003 in all these case scenarios, either septal or epicardial. And I use Cyan in septals after 003 fails, and sometimes even cyan block and filter wires. Coming to microcatheters, my default microcatheter is Corsair Pro for septals, for Caravel for epicardial collaterals, and also tortuous septals I use Caravel, and Fine Cross wherever these two are not working. I switch to Fine Cross. You can see when microcatheter is not crossing septal after getting crossed with wire, you can use all these techniques. You can enhance guide support, or you can change microcatheter based on the property you need, like pushability or flexibility. And you can see here that's how these things behave. And also you can dial it with 1 mm balloon or 1.25 balloon to push the microcatheter across. And you can see here, this is a septal collateral we crossed in an RCS CTO, but catheter was stuck here. We dilated with 1 mm balloon, and then you can see how the Corsair is going across the point where it was struck before. And also it's a similar case where we dilated with the balloon and subsequently went across with Corsair. And also we used an anchor balloon. You can see here we anchored in the OM branch to get through the septal collateral. So, and sometimes, if microcatheter is not crossing, you can see here caravel is not going across the epicardial collateral. So we switch to fine cross. So when there is a huge tortuosity, fine cross works better while crossing when size is not a problem. So fine cross crosses better, in tortuosity. And if microcatheter is not crossing despite all the efforts, you can do a kissing wire, or you can also do ADR. You can see in this case, so tried antegrade, couldn't succeed and went retrograde. But the problem is microcatheter got stuck in septal collateral. So that's when I had to use a marker wire. Use retrograde wire as a marker for antegrade wire, and then you can complete procedure. And you can see, yeah. And sometimes we can also switch strategy, like here, ambiguous cap, didn't have as good cap puncture, but the wire went subintimal. So then I came retrograde. The problem is, microcatheter got stuck here. Fine cross couldn't cross, and then shifted to quartz-air, couldn't cross. And then we did an ADR. So you can take a stingray and re-enter. By using retrograde wire as a marker, we can do a stingray re-entry, and we finished procedure. So you can also switch strategy when your microcatheter is not crossing collateral. So connecting spaces is a very important thing in a retrograde intervention. You can see once you are there with retrograde, either you continue with your wire proximally, or you can bring your antegrade wire discipline to true lumen using this as a marker wire. These are the only methods. The most common method used is reverse cart. To bring your retrograde wire into antegrade space, and this is my data, and in general the shows it 64% is reverse cart. So there are different reverse carts, but since this article came, these are the 3 reverse carts which we should understand. In fact, I can't go through this completely as time is limited, but this is something which you have to know: director reverse cart. So what we do here is, first is antegrade preparation, and then bring your retrograde wire and keep your retrograde microcatheter ready, and bring an antegrade balloon which is small, either 1.5 2 mm balloon, and then bring retrograde wire, directable wire like Gaia 2 or Gaia 3, and get into the space created by your balloon. So this is director reverse cart. The reason why it is important is that this is what we did here in this case. So antegrade preparation, and then retrograde wire, and then we took an antegrade balloon like 2 mm balloon, retrograde Gaia 2, and in 2 orthogonal views you direct the wire towards the balloon, either end balloon technique or side balloon technique, and you can complete procedure. So why it is important? So it avoids creating multiple wire tracks, so that you will become successful in reverse cart in shorter time. So that's the most important thing. That's the reason director reverse cart is recommended in most of the cases. Wherever we fail with the director reverse cart, then use conventional reverse cart, or in patients with calcified lesions and tortuous vessel also, conventional reverse cart works better. In this, you use a vessel which is equivalent to the size of the vessel, and then you direct retrograde wire into the space, either pilot, or it can be directable wire. So that's a conventional reverse cart. So, and when reverse cart is not so, and this case a post EBG CTO with a SVG on distal RCA. So that's when when you are going retrograde, your wire can go into SVG rather than into the mid RCA. So always bring your antegrade wire, and then you take your retrograde wire using antegrade wire as a marker through the CTO, and then only you can connect the spaces. Otherwise it is very difficult to connect the spaces. So that's what we did here. So this is an antegrade wire and this is a retrograde catheter. So we directed retrograde wire towards antegrade wire in two orthogonal views, and then we tried connecting two spaces, but we failed to connect spaces for a longer time. So that's when I did IVUS. You can see here, I'll show you. In frames. So you can see here it is subintimal retrograde wire, subintimal, and it came to intima, that is, and again when I came proximally it went to subintimal. So that's what happens. So comes intima and then goes to subintima. So what we can do is, where the wire is in intima, so you take your guide extension there and take a polymer jacketed wire from retrograde and bring your retrograde microcatheter here and take a polymer jacketed wire and then externalize. So that becomes easy. So that's what we did here. So and finally we got a good result. So in ardoastial CTO, what is most important is only retrograde is the option here. So and you have to have an externalization strategy. So once your wire is in aorta, so you have to externalize by snaring wire. You can snare wire here or here or here. So best is in descending thoracic aorta, because you don't create any kind of embolizations in descending thoracic aorta, significant embolizations. If you do in ascending aorta, you can cause an embolization to cerebral vessels. So that's what we did here. So we did externalization from left subclavian and then we finished. To conclude, retrograde in poor LV function scenario, consider MCS due to hemodynamic consequences. Ardoastial lesions, have a clear plan for externalization. Hostile LED L6 or major bifurcation with ambiguous cap. Always do IVUS guided antegrade proximal cap puncture followed by retrograde, not direct retrograde. All other cases, my strategy would be antegrade preparation first followed by retrograde if needed, unless there is specific contraindication. Choose interventional collateral carefully and treat the critical donor vessel disease before going retrograde, and know the subplots to circumvent, like wire crossed but microcatheter not crossing the septal collateral, one subplot, and difficult reverse cart is another subplot scenario, and difficult externalization is another subplot scenario. Have all the backup algorithms for these three, and then you can increase success rate of your retrograde interventions. Thank you.